So our next speaker is going to give us a lot of ideas out of the box thinking styles. So Dr. Ashok Nataraj, thinking out of the box to publish.
So actually, this cross was taken by myself upon me, actually, this out of the box. So I cannot complain. So thinking out of the box means initially I thought, I just sat in at a box and started looking out, whether I get any ideas. So thinking out of the box means, it is something like it should be out of the world, it should not be straightforward. Like, you want to do something, how routinely we do. Thinking out of the box means doing something really weird and wacky. So when I went through the net, see, there was about thinking out of the box. This is a puzzle. Okay, you got these 9 dots. Now you should use only 4 lines. Okay. And when you're joining all these, you have to join all these dots, okay? And you should use only 4 lines. And every time you should not take your pen off when you're drawing the line. You should not take it out. It should be continuous. And you should not go over the line back and forth again. Okay? So how are you going to do it? So this is the funda of out of the box. Okay. So this is without lifting the pen or overdrawing on a line. How will you do it? Okay, so this is how you should do it. So what you do is, you go like this, you go like this, you go like this, and you come. Okay. So it is like, you are going out of the framework. Okay, you are not within the framework of normal thing. You are going out of the framework. See, whenever we say, you have to solve something, you want to remain within those dots, correct? So when you have to think out of the box, you have to go outside the framework, and that is why all realized souls and all that, they go out of the framework, and we are all within the framework. So that's a difference. So that is the importance of thinking out of the box. Okay, so I think you should meditate a little bit before you think out of the box. So this is a famous saying by Sherlock Holmes: "You see, but you do not observe." So he always tells Watson, whenever he is able to deduce a lot of things from a crime scene, Watson says, "I'm also saying the same thing. How did you understand?" So he says, "You see, but you do not observe." That's something which commonly he says. So now, I have 2 situations, one in medical retina and one in surgical retina. In retrospective analysis, I thought out of the box. So I'm just trying to present. It's not theory, it's just 2 cases, that's all. Okay. So this is case 1. This is a patient, this is a fundus photo, as the left eye. And this patient was having diabetes. Okay, this patient was having diabetes. And this is a right eye. Okay. And you can see, maybe you can say mild NPDR or very mild diabetic retinopathy. And this was the patient's left eye on presentation. See, what you can see is, you can see a hump there, no? Hump. So this is a fovea. Hump close to the fovea means there is macular edema close to the fovea. And you can see a red dot here. See, a red dot, correct? So this is a section through the red dot. Okay, through the red dot. And what you can see one round thing, no? Round thing. Okay. So when I saw this patient, I thought it was diabetic macular edema. So nothing to be done. CME is there, minimal CME. There is an ERM also. So you observe. Okay. Then, as Madam was telling, the red book. By the way, we are keeping red books there. All PGs you can buy. We are sponsoring. All red books are there. You can take it when you go. So it's like, I saw this patient, I just left it. Then after some time, another patient came. He was having mild NPDR in one eye and little more moderate NPDR in the right eye with macular edema. So similar thing. Okay, similar thing. And when I did an OCT, you can see the FFA image here. You can see a dot here which is enlarging. And when you take an OCT through that, you can see one white thing here. See, this is also common for this patient. Okay. So this is basically a capillary which has become enlarged. Okay, this is a capillary which has become really enlarged. So a new concept, something called PVAC, PEVAC. That's called perifoveal exudative vascular anomalous complex. I was saying it again and again so that I should not miss it. Now only I also got it, so you don't have to worry. Not backshadowing, you can see a round thing, no? You can see a round here. This is a dilated capillary. This is a PVAC lesion. So, but unfortunately, in all our literature, PVAC occurs in patients who don't have diabetes and who have controlled hypertension. So that doesn't fit our bill, because these patients have diabetes, correct? So whether these PVAC kind of lesions are causing macular edema. So that is our next question. So we have to think out of the box. We have to go out of the framework of diabetic retinopathy. See, it's like you tie a calf to the coconut tree and talk about the coconut tree. It is something like that. Okay. So like that, then we gave anti-VEGF. This is diabetic macular edema. We keep on giving anti-VEGF. But the patient didn't respond to any anti-VEGF. You can see this dilated capillary here, not responding to anti-VEGF. Then we gave Osidex, there was a good response. But unfortunately, after 2 or 3 months, again it recurred and we had to keep on giving Osidex. So then only we did a literature search and we found that this is exactly how a PVAC lesion will respond. They don't respond to anti-VEGF at all. And this was one of the first reports where they were responding to Osidex intravitreal injection. So we call it PVAC-like lesion because we cannot say PVAC because for PVAC the patient should not have diabetes, controlled hypertension. And I should not say I got IGO certificate of merit award for this, along with madam who got the best reviewer award for IGO, so that she cannot complain. I'm saying my own thing. That's why. Okay, so this is kind of thinking out of the box. So I followed this up. This is another case. Similar presentation. You have this macular edema here. Okay, so right eye diabetic retinopathy. Patient has diabetic retinopathy. Okay, in the right eye you can see microaneurysms. Left eye the same hyperfluorescence there. And you can see this dot here and you can see this giant aneurysm here again appearing. Okay, this is macular edema. You have to give anti-VEGF, no? Okay, I gave anti-VEGF, I gave Osidex, nothing is working. Then what I did was, I did focal laser to this giant aneurysm. Okay, focal laser, flat. See, macular edema is decreasing, macular edema is gone. So that? So that is the key, that point is the key. The earlier patient, I didn't give focal laser because it's very close to the fovea. If you give focal laser, macular edema also will go, vision also will go. So we don't want that. So this is very much away from the fovea and this is how. So this is something, see, you have to get out of the framework of diabetic retinopathy. New things can happen. So what they say about PVAC is there is reduced expression of metalloproteases in the basement membrane. So that causes greater pericyte loss and that leads to this giant macroaneurysm kind of thing forming. Spade is called as RCMA, retinal capillary macroaneurysm. You can call it by any name, but this is what happens and this can occur even with diabetic retinopathy or, controlled, even in hypertensive. So this is one thing I would like to say. So this is like thinking out of the box. You give focal laser to that. I didn't do anything else. Just focal laser over a period of 1 or 2 months, the whole macular edema resolved. Okay. Then I will show you one case in surgical retina. So the theme here is necessity is the mother of invention. See, you do things only when you are pushed to the wall. So you don't know whether you can climb the wall unless and until a dog really chases you and you are running for your life. Okay, so that is the basic thing about necessity is the mother of invention. So when I do macular holes, I do something called as inverse flap technique. So and I don't know, I'll just tell you, see, when you're doing macular hole, you do something called as vitrectomy, you remove the vitreous and you go on top of the retina. Retina's got 10 layers. Okay, the innermost layer is called internal limiting membrane. So this internal limiting membrane is known to cause tangential traction and that is why macular hole is there and you have to remove the internal limiting membrane so that macular hole closes. So whenever there is a big macular hole or you feel macular hole will not close in regular surgery, what you do is you peel the internal limiting membrane but from the edge of the macular hole, whatever internal limiting membrane you have peeled, you stuff it into the fovea. Okay, and that is called as inverse flap technique and improves the closure rate. So what happened is, when I was doing this process, I just lost the ILM flap. Now I don't know what to do. How can I put the internal limiting membrane? I just lost it because it's a fine thing. Around the hole you have to peel and just stuff it inside. So I just lost it. What will you do? So this is what I did. This is the whole thing. The peel lost flap, center is a macular hole, and the green thing is remaining internal limiting membrane. So I took a peel from the edge, and I took it and I stuffed it in the fovea center. Okay, this happened at the moment. I never thought about this. I was pushed to the wall, and instantly I thought I should do this, and I did this. So I'll just show you a video how I did this. Okay, so this is the internal limiting membrane peeling. You can see. So I'm just tucking it in. See, this is called the tuck. You have peeled it. Now you just see, got it, lost. Flap is gone. Now what can you do? Then see, you can see it's going from there. On the side, I peel there and take that. Slowly I bring it. It's not too much time, don't worry. And bring it close and stuff it out of the fovea. See? So this is one out of the box technique that you can do. So this is the outcome. This is the open hole, peeled. You can see it there, and the macular hole is closed. This is something called as the outer retinal defect. People who have this outer retinal defect have very good prognosis. Don't think that there is a hole and patient lost vision. Okay. So this is another case. Again, a lost flap. This is another case. This happened after I did fluid air exchange. See, once you do an inverse flap technique and then you fill it with air, and then you exchange it with C3F8. Now, this I was doing really well. You can see I'm peeling, putting it in the center of the hole. Everything is okay. Now I'm trimming the flap, okay, because you don't want a big flap. You trim it with cutter so that it remains in the center. Now also it's okay. Yeah, it's staying. Now I fill it with C. This is called inverse flap. You put the flap on the fovea. Now I'm filling it with air. That's called fluid air exchange. Okay, so you can see it's getting filled with air. See, air is filling. Now, because when you fill air, the flap will move a little bit to the one side. So you want to tuck it back to the fovea. So unfortunately, with the flute only I tried. So I'm tucking it in. I'm still not satisfied. Then what happens is this flap just comes off from the center. You can see. See, flap is gone. Now what will you do? This under air also. Now you cannot remove the air, but under the air I want to do the same thing. Okay. So again I do the same thing. I take it off. Because under air it's really challenging because visualization is really bad. No? So under the air I really challenging and I just did it. And that's it, same thing. And this is the result. This is perfectly closed. Okay. So unfortunately, when I went back, in 2015, a Japanese fellow has done the same thing, even without my knowledge. And it has already come in cataract surgery and ophthalmic surgery and lasers, the same technique, what he has used. See, the same thing can happen, I've never read that article before. I did it in the spur of the moment, but same thing can happen. But anyway, I got it published in the VRSI journal. I could present on the VRSI also. VRSI is Veterinary Society of India meeting, VRSI. Okay. Thank you very much.
Thank you very much. That was very interesting. We all, I think, enjoyed it. Many of us who are PG teachers in institutions like the RIO, we have to deal with 10 to 12 novel ideas every time there is an intake of PG. So we shall keep all of your ideas in mind. Thank you very much.